Well, buongiorno, good morning, and we welcome Mervyn Singer at the podium. We all have the same conflicts of interest with all the sponsors of this meeting, which helped us to make this possible. Thank you for being on time. I have some news for you. Tomorrow we'll start at 8:30, not at 8. So you can sleep a bit later. It's Wednesday, and we thought it would be acceptable because we'll have one talk less tomorrow. So these are the news for this morning, and now let's speak about the reference in hemodynamic monitoring. And I will argue that the pulmonary artery catheter still has a place today, but of course we need to use it when we need it, and we should not overuse it. But the pulmonary artery catheter offers the package, and a reliable package, with measurements of intravascular pressures, pulmonary artery pressures, wedge pressure, right atrial pressure, cardiac output and stroke volume, and mixed venous oxygen saturation. For too long, actually, people have only looked at some of these variables, not all of them. In particular, a number of people have neglected the measurements of SvO2 using the pulmonary artery catheter. And at the same time, it's clear that some time ago, there was an overuse of the PA catheter, but now I think there is a risk of underuse in many centers. When you talk to colleagues, or perhaps it's the case in your institution, people often say we use less and less pulmonary artery catheters. Actually, we can do without it. We don't need it anymore. We are very, very good. But then people start to realize that they use the pulmonary artery catheter less and less well. If you use them less commonly, you start to have some problems during the introduction of the catheter, and you start to have problems with the interpretation of the data. So after all, I think people start to realize today that the PA catheter remains a good tool. Oh, it's very invasive. Is it really so dangerous? Have you seen many complications recently? Clearly, in our institution, we don't see many complications related to the use of the pulmonary artery catheter. But there is still a great need of teaching, as we will see in the next minutes. Well, actually already now. How do you interpret this? A right atrial pressure, or a CVP of 12, and a pulmonary artery balloon occluded pressure of 8. Yeah, I even give you the mean pulmonary artery pressure of 28. I sometimes hear, I don't know, but I don't care, I don't use the pulmonary artery catheter anymore. That's the wrong answer. Physiology remains. And that's what I like in intensive care medicine. It is that we can try to evaluate the pathophysiologic alterations at the bedside, and from there we find the optimal treatment. So we wrote this piece recently with a number of speakers who are here and others, claiming that we should use the pulmonary artery catheter when needed, and of course not when it's not needed. So if you feel that the PA catheter will not help to guide therapy, just collecting numbers will not help. And yet throughout the world, there are still people collecting numbers and not doing anything with them. That may apply to the PA catheter or any other monitoring technique. But if we feel that this could influence our therapy, then there should be proper data collection, proper data interpretation, and proper data application. I think there are 3 steps. And there are risks of errors at each of these 3 steps. Sometimes, let's say, the wedge pressure is not taken accurately, or the SvO2 signal is not good, and yet people collect the SvO2 data. Sometimes, once this is done properly, people don't interpret it correctly. And they may actually apply it in the wrong way. Even if they have a good interpretation, they still give fluids when the interpretation was hypervolemia, or they still restrict fluid when the interpretation was hypovolemia. I need to spend a few minutes to discuss this. The PA catheter has not been shown to decrease mortality in randomized controlled trials because this is a strong argument used today to avoid using the catheter, saying there is no evidence it improves outcome. And it is invasive, so we should not use it. Remember the Pro and Connors? Remember Connors many years ago? When Connors suggested in 1996 that there could be increased mortality, prolonged length of stay with the use of the PA catheter. There was no good explanation for this. And actually already at that time we argued, more than 10 years ago, that they were overusing the pulmonary artery catheter in many of these American centers. Because in the first EPIC study, we used the PA catheter less commonly in Europe than it was in the Connors study. And in the SOAP study more recently, when the PA catheter was used in 15% of our ICU patients, we found that using the same methodology as in the Connors study, that the pulmonary artery catheter was not associated with a worse outcome. Using propensity matching, there was no difference in mortality rates with or without the PA catheter. Now, you may argue that there was no benefit with the use of the PA catheter either, but these are indeed the data. Our use of the PA catheter in Europe was also much lower than in the Connors study. So now let's look at the protocols used in these various studies. And actually our chairman has contributed to this literature as well. But usually in these studies, the question was asked, could I do without a PA catheter? If the answer was no, then a PA catheter could be inserted, because ethically people felt it would be inadequate to sorry, what's going on? Yeah, no, I don't need to check my email now. People did not feel that it was ethically acceptable not to insert a PA catheter if it was indeed clinically required.
Have you brought a pillow?
But here we go, voila. And then, if the answer was, yes, I can do without a PA catheter, then patients were randomized for a PA catheter or no PA catheter. And of course, there was no difference between the two groups, because these patients did not really need a PA catheter. In the look at the ARDS network study, which is a nice study showing that we don't need a PA catheter in every patient with ARDS. We know that, and actually I think that we knew it before the study was done, but they needed to consider 11,500 patients to enroll 1,000 patients in the study, because if the physician felt that a PA catheter was needed, or if the patient already had a PA catheter in place, of course, this patient could not be randomized. But secondly, it's a monitoring technique, and let's admit that if we review all types of monitoring techniques, we don't have much evidence that any monitoring technique improves outcomes. And our review there put into perspective the recent negative studies on the use of the PA catheter in the acutely ill patient. So this could be true for the other techniques we are discussing at this meeting, including even echocardiography, as Antoine reminded us yesterday. But my point is here, the most important one. If there is no improvement in outcome in these studies, what are the possible explanations? And I showed you this slide the day before yesterday. It should be either that the additional information does not influence management, or that changes in management do not improve outcome. And this is really very important, because one explanation is that it does not influence therapy. We are just collecting numbers and it won't change our therapy. Or our therapy does not improve outcome. Or actually our therapy could sometimes make the outcome worse. So that's very worrisome, I think. Now, many people don't like monitoring systems because they cannot use protocols. And especially in North America nowadays, people like to use protocols on everything. And as we mentioned yesterday and the day before yesterday, actually better monitoring systems may help us without necessarily rigid protocols. If it helps us to base our treatment on pathophysiologic alterations. But adequacy is not synonymous with normality, and correct application must integrate many variables, and that's how it's so difficult to develop protocols. But if we use a PA catheter, we need to measure, interpret, apply. If people don't do it very well, it's because they need more teaching. Would we abandon the EKG because doctors cannot interpret it correctly? It's the same thing here. I'm afraid that many people do not use the pulmonary artery catheter adequately. Let's go over a few elements. Pressures. Very often, once people measure pulmonary artery balloon occluded pressure, they just neglect the right atrial pressure. Let's return to this. How do you interpret a right atrial pressure which becomes higher than the wedge pressure? Even in my department, it's not uncommon that nurses do not interpret it correctly. We need to understand the various determinants of the central venous pressure: blood volume, right ventricular function, pulmonary artery pressures, left ventricular function, intrathoracic pressures. So if we look at a single relationship between cardiac index and CVP, this would be hyperdynamic, this would be hypervolemia, this would be hypovolemia, this would be right ventricular dysfunction, cardiac output is maintained, this would be right ventricular failure. Now, if we go to the wedge pressure, now we bypass the pulmonary arteries themselves, and now we have left-sided filling pressures. In other words, if there is such a difference between the two, if the right atrial pressure is becoming higher than the wedge pressure, it's probably because there is pulmonary hypertension. Then we need to look at cardiac output to see if it's dysfunction or failure. And as it was reminded yesterday, in the presence of right ventricular failure, we may consider vasodilators, the butamine. If the blood pressure is low, we need to restore right ventricular perfusion pressures. So that's the kind of algorithm that I would have in mind in the presence of differences in filling pressures. What do you think about this? Pulmonary artery pressure is 25/15, wedge pressure 19, right atrial pressure 12, cardiac output 3.9 liters per minute. I love to ask the nurses at their exam, and they usually know what to reply because we tell them. But I know that there are some people in the room who do not interpret it correctly. It's impossible. You cannot have a wedge pressure which is higher than the diastolic pulmonary artery pressure. If there is a V wave, you should not take it into account, and the wedge pressure can only be equal or lower than the pulmonary artery diastolic pressure. What about this? Mean arterial pressure after aortic valve replacement goes from 75 to 85, the wedge pressure from 13 to 23, right atrial pressure from 9 to 19, cardiac output didn't change. What is your interpretation? There is only one interpretation, but if you miss it, good luck. It's just there was a change in position, change in zeroing. Otherwise, you cannot see a change in pressures without a change in cardiac output. I'm already discussing cardiac output, and SVO2 will come together. Because to interpret a cardiac output value without knowing what the SVO2 is, in my mind, is very difficult. And I showed the slide already the day before yesterday, I believe. Cardiac output is high, SVO2 is high. Cardiac output is high, SVO2 is low. Cardiac output is low, SVO2 is high. Cardiac output is low, SVO2 is low. These are the four types of patterns that we could see. Actually, today, I look at SVO2 before I look at cardiac output and filling pressures. In the past, it was just the other way around. We started with pressures, then we look at cardiac output, then we added SVO2. I think it should be the other way around. Because I stand by this. Hemodynamically speaking, when SVO2 is high, there is not much you can do in terms of hemodynamic management based on this approach. You shouldn't give more sedation, you shouldn't give transfusions, you shouldn't give more dobutamine, more fluids. No. It doesn't mean that the patient will do well. Of course, a patient with extended peritonitis may have a very high cardiac output, a high SVO2. But in terms of hemodynamic management, I don't know really how you can further improve that particular situation. I like to look at cardiac index versus oxygen extraction ratio. We actually use it regularly in our department. Inflammatory states would be there. That would be, in you and I, exercise. In ICU patient, more probably anemia. That would be low flow states, rather low cardiac output, low SVO2, and that would be low oxygen demand. Low cardiac output, normal or high SVO2. So you can look at it on a screen, you can have it at the bedside, you can see how patients may actually go along these various isoplets during an intervention. It's really something that helps you to apply physiology at the bedside. Measure, interpret, apply, and you have the answer quite quickly when you influence the system. A patient after cardiac surgery has a CVP of 7, a cardiac index of 3.7 liters per minute per square meter, an SVO2 of 60%. What is your interpretation? Cardiac output is high, right? 3.7 liters per minute per square meter. Maybe the output will be at 6 or 6.5 liters per minute. So, well, either increased VO2 as in exercise or decreased hemoglobin or possibly hypoxemia, but hypoxemia I can eliminate it quite quickly with my pulse oximeter. So these are the 4 hemodynamic patterns. Low SVO2, low cardiac output, all together, low flow state. High SVO2, low cardiac output, all together, there is only one explanation, low oxygen demand. As I tell my students, I don't give you much money at the beginning of the month and you leave a lot of money on your bank account. At the end of the month, there is only one explanation. You didn't consume much. Low SVO2, high cardiac output, that's already what we have when we exercise. Patients may be stressed in their bed, but they don't really exercise in their bed. Usually it is more compatible with anemia. High SVO2, high cardiac output, inflammation. It could be hypervolemia too, in a patient with renal failure, for instance. Grand mal Caesars, that's exercise. Acute bleeding, low flow state. Barbiturate coma, low oxygen demand. Ventricular tachycardia, low flow state. But looking at changes over time is even more appealing. Look at this. Cardiac output went up 3.5 to 7 in a few hours. SVO2 went down. What is your explanation? Well, could be a patient who was sedated, now is alert, weaning, extubated, anxious. Well, if it's the other way around, cardiac output went up, but SVO2 went up. What do you think? Well, fluid repletion, increased contractility, vasodilation, sepsis. Think at the 4 determinants of cardiac output and start to play with this. The other way around, cardiac output goes down, SVO2 progressively increases. What is your explanation? Well, it could be just the other way around. The patient now is intubated and mechanically ventilated. If SVO2 goes in the other direction, from 7 to 3.5 liters per minute, SVO2 going down, it may be development of hypovolemia or heart failure. So you can play like that for a while. Yeah, that's an interesting thing. Following that intervention, the only thing that changed was a decrease in SVO2, one resident told us. Is it possible? Of course not. There must be a decrease in PO2, but then cardiac output should increase. There could be a decrease in hemoglobin, but then cardiac output should increase. There could be a decrease in cardiac output, but cardiac output didn't change, we are told. It could be an increase in VO2, but cardiac output should increase. So you must have some change in cardiac output accompanying the change in SVO2. If SVO2 increases, cardiac output increases. Think at the various ways to increase cardiac output. If SVO2 increased, cardiac output decreased, it must be decreased VO2. If SVO2 decreased, cardiac output increased, anemia, hypoxemia, increase in VO2. Or again, look at your 4 determinants of cardiac output. I know you would like to be less invasive. You would like to have perhaps a simpler way to determine cardiac output. My problem is the interpretation of cardiac output with these techniques. Of course, as I said the day before yesterday, echocardiography can be very helpful, but it complements the pulmonary artery catheter. You may say, let's look only at SCVO2. I do not entirely agree with my friend Keith Wille when he says that SCVO2 is a good surrogate for SVO2 because the interpretation of SCVO2 is actually relatively complex. And if you look at this data, again showing a good correlation between SCVO2 and SVO2, when you look at a single value, an SCVO2 of 80%, it may correspond to a relatively large range of SVO2 values. Likewise, if you look at an SVO2 of 70%, really the range of SCVO2 can be quite large. So if you read any of these papers, you can see that in the discussion section that actually the authors were quite prudent in the interpretation of their data. You may say that trends are better. I don't agree. If you look at delta SCVO2, delta SVO2, it's not that good. And again, Koplerides just published this paper suggesting that SVO2 and SCVO2 are not equivalent with a relatively large bias and relatively large limits of agreement. So SCVO2 is the SVO2 of the poor. Again, with the PA catheter, we have a package. And you can see now my point. People say, well, maybe we can do only with CVP. Maybe we can do only with a less accurate monitoring technique for cardiac output. Maybe we can do only with SCVO2. If the patient is critically ill, these approximations just add to each other, and this is not entirely satisfactory. With the PA catheter, you have some kind of package, which remains important today at the end of 2009. I think the PA catheter still has a place, but in medio virtus. Thank you very much.